بسم الله الرحمن الرحيم. أهلا بكم طلاب وأطباء طب الفم والأسنان في International Online Dental Uses Congress في نسختي الأولى من اتحاد الجامعات العلمية لطب الأسنان وحديث التخرج، والتابع ل EADS Egyptian Association of Dental Students، وهي الجهة العلمية الوحيدة الموثقة في مصر والتابعة للاتحاد العلمي فيما يحض الطالب وحديث التخرج داخل الجامعات المصرية. وهدفنا هو تطوير وتعليم طلاب الأسنان في جميع مجالات الأسنان، كما نهدف إلى تطوير الطلاب في أجزاء أخرى مثل السوفت سكيلز. ونحن متواجدين الآن في أكثر من 33 جامعة، ويتضمن المؤتمر أكثر من 100 دكتور من مصر وخارج مصر من الدول العربية والإفريقية المختلفة من كبار الدكاترة والأساتذة المتواجدين. وسوف تحصل على شهادة معتمدة بعد حضورك نسب الحضور المطلوبة للمؤتمر. وهناك سحوبات يومية تصل قيمتها المالية إلى 4000 جنيه مصريا، وإجمالي السحوبات في المؤتمر تصل إلى 50,000 جنيه مصريا. ونعلن عن الشراكة بيننا وبين دول لبنان، فلسطين، السودان، رواندا، قطر، السعودية، تونس، المغرب، تنزانيا. نتشرف بالإعلان عن البورد الرسمي للمؤتمر رئيس المؤتمر الأستاذ الدكتور عبد الفتاح صدقة، الرئيس الشرفي للمؤتمر الدكتور حاتم الجندي، السكرتير العام للمؤتمر الأستاذة الدكتورة هالة هزاع، اللجنة العلمية للمؤتمر الأستاذة الدكتورة عليا محروس، المشرف الأكاديمي الأستاذ الدكتور جايان الجندي، الضيف الشرفي للمؤتمر الأستاذ الدكتور شذا حماد.
تمام يا دكتور، ممكن حضرتك تبدأ.
Okay, you can hear me? Can you hear me, guys?
يا دكتور كله تمام، اتفضل.
Okay. Thank you guys for the invitation. I appreciate it, and I'm really happy to be with you today. The topic is a controversial one. So I know many people who love the fiber post and many people who hate them. I know many clinicians who get angry if I say something bad about the casted post and core, and I mean really angry. But again, that's why I chose this topic today. I feel pretty safe behind the screen, so I don't mind upsetting anyone. I will present the truth as I know it to you guys, and I will show you some evidence, obviously, to support it. So, as I said, many people don't like the fiber post. And I have a problem with the current way we are naming things. So, yes, a fiber post does contain fibers. Try to break one and take a good magnified picture, and you can see those fibers embedded in the resin matrix. So if we zoom in, you can actually see those fibers inside of the fiber post, which are embedded in the resin matrix. So technically, the fiber post is a composite. And I know many people who think that it's a type of ceramic, and it's not. It's simply a composite. So because of that, I have no problem with calling it a fiber post because it's made out of fibers embedded in a resin matrix. Except when we start to look at how we are naming its neighbors or its closest relatives, okay, like the metallic post and core, or like the screw post, for example, we will find that there's a problem in the current nomenclature, in the way we are naming those posts. The screw post is obviously screwed inside of the tooth structure, so it makes sense to call it a screw post. And I think, and I believe, and I know that many people believe that it's one of the worst restorations that could be ever used in the dental practice. So if I see a screw post in a dental clinic, and don't be mad if you're one of the people who might use it, I would know that this specific dental clinic is practicing low quality dentistry, because we know that there are different levels in dentistry. There's good dentistry, and we already know that there's bad dentistry being practiced. A screw post causes lots of problems in tooth structure because of the action of screwing it inside, and we know that we should not use it. So I have no problem with the screw post. The post and core as well, the metallic casted post and core, also I have no problem with naming it as a post and core. Why? Because when it fails, okay, the post fails, which is in the radicular part, and the core also fails with it because it's attached to it. So it makes sense to say that my post and core, for example, failed as a whole. I have no problem with that whatsoever. However, when we come to the fiber post, whenever the fiber post fails, I know, and I hear it from many of my colleagues, I hear them say, the fiber post failed, okay? Or many people say that the fiber post fails a lot, or don't use the fiber post in the posterior area because you have heavy forces. So when the fiber post fails, is it really the fiber post alone that failed? In that tooth where you were trying to restore function and, let's say, aesthetics, you placed a fiber post. Is it really, when it fails, that the fiber post is failing, or is it failing with something else? Obviously, it's failing with something else. So the fiber post never fails alone, okay? 99% of the times we see the fiber post failing at least with the core, if not with the core and crown, and yet it's held responsible for the failure. Why is that? So this whole thing failed, and when I want to blame something for the failure, I blame the fiber post. And that's why I think that it's nonsense. So the core is bonded to a bigger surface area when compared to the post. In contrary to what many people believe, the area of contact between the post and the post space is much less than the area of contact between the core and the pulp chamber. Add to that also that the bonding with the dentine in the pulp chamber is much better than the bonding of the resin cement with the fiber post to the radicular post space, as we all know, because of the very high C factor inside of the post space. So again, why are we saying that the fiber post fails? I always feel like the core is getting a free get out of jail card. It's not held responsible for anything every single time we blame the fiber post. And that's why I think just saying fiber post in our day-to-day interactions when we try to communicate with each other is slightly unjust. And the fiber post is being held responsible for failures, which is not its responsibility. In my opinion, the correct way to name these things is as follows. So I like to categorize them as a prefabricated post and core and a custom-made post and core. Obviously, the screw post, I'm not going to mention it because we should not be using it. With regards to the prefabricated post and core, obviously, it's going to either be a fiber post and a composite core, or a metallic prefabricated post, and these things exist. Commercially, they exist under the name of parapost. You can buy them, just similar to a fiber post, but metal, and you put around it an amalgam core. So in this case, it's a metallic post and core system, but it's prefabricated. In this case, it's also a metallic post and core system, obviously a different kind of metal, but it's custom made. We have to fabricate the pattern in the clinic, then send it to the lab, and the lab should custom make it. By the way, I'm going to stop 2 times during the lecture to take any questions. Okay, I'm going to stop in the middle. If you have any questions, you can ask me, and I'm going to stop by the end also. So if we can agree on that, you and I can become best friends, and we can continue this presentation very peacefully. after we've agreed on the correct way to name those restorations, let's see how the casted post fail. If we go and look into the evidence, the most comprehensive review of failure within orthodontics in general, and in this study specifically, the posts and the cast posts, 2,874 posts were followed up in this study. So that's a big number. And in research, we like big numbers of samples because they give more accurate results. So a huge number of posts was followed up in this study. Despite the individual differences, obviously there will be variability because many of these posts maybe are placed in teeth with one missing wall, others are placed maybe in two missing walls, others are placed maybe in three missing walls. Varying degrees of ferrule available in this study, but still the big number compensates for that. What Goodacre found in 2003 in this very well-known study is that you get 10% complications with the casted post and core system. So if you place 1,000 casted post and cores, let's say within the period of 6 years, he expects that 10% of them are going to fail. So you will end up with 100 failures, which is, in my opinion, a pretty big number. 5% of those failures are caused by post dislodgement, so loss of retention. 3% root fracture, which we rarely see with the fiber post. And 2% he classified as other causes. Let's compare that with the fiber post. And in my opinion, the most relevant piece of literature that we have is from Neumann in 2012, because this was the first prospective study evaluating fiber posts. So what they do in this prospective study is that they get the patients and they select the teeth that they want to restore so that they would have similar conditions. But to do that, you cannot include that many number of posts. And that's why you can find that in this study, we have only 149 posts available for our study. In the case of Goodacre, it was 2,000 posts. But still, since this is a prospective study, it ranks higher in the hierarchy of evidence. In his study, Neumann finds out that 55 of the 149 failed within the 10 years. So the study was published in 2012, and this means that the earliest post placed in this study should have been placed, let's say, in 2002 and 2003, because the study was published in 2012. He found out that we have a 4.9% annual failure rate. So if you want to know the failure rate in 10 years, just multiply that and you'll get the number. It's crazy. Can you calculate it? 4.9 times 10. So we have around 49 or 50% failure in 10 years, which is a very big number for fiber posts. And from this, I can understand why many clinicians hate the fiber post. I know that in some dental schools, students are even not allowed to place a fiber post in the posterior region because they get scared that the fiber post might break or gets dislodged or a failure might happen. When I see this study, I understand the cause of this paranoia coming with the fiber post. But the funny thing is that Neumann in his study finds out that the anteriors are 2 times more likely to fail when compared to the posteriors. So if you think that I don't want to put a fiber post in the posterior region because I want a metallic strong post that can handle the forces, you are mostly wrong, because in the anterior, you're twice as likely to fail. And I'm sure many of you have seen in the clinics and their own clinics all the time failed fiber posts and even casted posts in the anterior region, central incisor, lateral incisor. We find failures in those kind of teeth much more commonly when we compare it to a lower 6, for example, or a failed complete casted post and core in an upper 7, for example. The posts and cements are from 2003. So think about that for a little bit. What do you think happened to the adhesive dentistry world from the 2002, 2003 to currently we're 2022 and we are heading towards 2023. So 20 years ago, I am sure the posts were different and the cements were different. So currently we have much better posts, much better adhesive systems. And obviously, again, with regards to these numbers, yes, we believe in the evidence. We believe that in general, on average, that's what we are going to find, but there are individual differences. So if this was true, and out of every 100 posts you will put, you will have 50 failed within 10 years, I wouldn't do fiber posts anymore. I would stop working in my clinic. And I haven't experienced that kind of failure with fiber posts. On the contrary, I've experienced amazing success with fiber posts. Within the last 10 years, I haven't had one fiber post fail. When Onetoone saying that you will get 50% failure with 10 years. Why do we have such a difference, and why am I personally experiencing some difference from the results shown in this study? Because most academics, and I'm one of them, okay, would like us to believe that the results of the study or the results of any study that we found are applicable to everyone and everywhere. So if you read a study and you find 5% annual failure rate, you are going to expect that this failure rate is going to apply to everyone. But to be honest, in the actual world, we don't see that. So yes, this is an average failure rate, but not necessarily that it's going to apply to you or to me or to my colleague, because there are variable differences and every clinician does his procedure different than the other person. Even if they were following the exact same protocol, we find many differences. We have variability in the skills of the clinicians. So we have to take that into account. Do we have a new 10-year follow-up prospective study on fiber posts? Obviously, we don't have, because the earliest would have had to happen in 2012, so that 10 years would pass, and now we're 2022. If you want to know the results of the current materials and the current techniques we are using, well, the result will end in 2032. So this is the evidence that we have. I've presented to you the evidence and the literature. But again, I did not personally experience this kind of failure, neither in the casted post and nor in the fiber post. And the primary reason for that, I believe, is the case selection. So it's very important to select your cases. If you choose such a case or such a tooth and you say or decide that you are going to place even a casted post instead of a fiber post, because you still believe in the myth that posterior teeth can't handle the fiber post and need a strong metal to operate, I want to ask you, how are you going to seal those margins while you are cementing the casted post? I'm going to ask you, where's the ferrule? For a long-lasting restoration, the margins of the crown must lie and encircle the tooth structure circumferentially, not in one area, but all around the tooth with 2 millimeters. The first real citing of the word ferrule was ironically in a textbook of endodontics, which is Pathways of the Pulp. You all know it. And the authors call it encirclement and ferrule. Very similar to this barrel. Without these metallic rings, the wood is going to split. So you need the crown to encircle the tooth structure and not the core. So whenever you find a case where you have to place your margins on the core, you have to know that it's going to fail. It's doomed to a failure. If not now, in 1 year, if not in 1 year, in the next year. The margins of the crown need to rest on at least 2 millimeters of sound tooth structure all around your tooth and not on the core. Obviously, we have lots and lots of studies on ferrule, but we know that the ferrule is going to decrease post dislodgement, so we're not going to lose the post, whether it's a casted post or if it's a fiber post. It applies to both. It decreases root fracture in the cases of casted post, decreases post fracture in the cases of fiber post. Obviously, we have never experienced a post fracture with a metallic post and core, and decrease in the failure of the cement seal of the core. Because remember, if you have your margins of the crown resting on the core, all of the forces of mastication are going to be transferred into this interface. So whatever the type of your cement, if it's a resin cement, if it's a glass ionomer cement, if it's a zinc phosphate, doesn't matter. With time and because of fatigue, this cement interface is going to break down and you will end up with caries, even if you don't end up with a post dislodgement. When you remove the post or when the patient loses his post, you are going to find lots and lots of caries in the pulp chamber and even your canals, and you will find that the tooth is no longer restorable. So if we have a crown and the crown rests on the core with repeated loading, we will have failure by fatigue of the cement interface. That's one way a failure could happen. And we could end up with many problems. If it's a fiber post, we could have a fracture. If it's a casted post and core, we could have dislodgement or transfer of the forces from the pulp chamber into the radicular region, causing a root fracture, a catastrophic root fracture. For this reason, the crown margins need to rest on tooth structure, and it's your job to make sure that that's going to happen. It's not the job of the dental technician. So you have to expose the margins of the tooth in these badly broken teeth. So this does not mean that you should use a casted post and core in cases where there's not enough tooth structure, because I've also heard that saying and that myth so many times in my life. Whenever there's not enough tooth structure, I hear someone saying, don't place a fiber post, it can't handle it, place a casted post. That's completely wrong. So when you don't have enough tooth structure, you simply don't do a post and core. So I was just talking about the cement seal, okay? And we have a study that investigates that. So in this study by Kovarik, 1992, it's a very old study, but it's a classic as well. The samples with the core and the crown, they get repeatedly blown, okay, with something we call a fatigue test. So we keep on hitting that core 1 times, 2 times, 3 times, 5 times, 100 times, 1,000 times, even 1 million times until we see a failure. And when the failure happens, we write down the number of cycles. So the higher the number of cycles, this means that this restorative material handled the stresses better. And the lower the number, that this means that it couldn't handle many cycles. So in his study, he had amalgam core, composite core, and silver modified GIC, glass ionomer cement. The glass ionomer cement almost always failed, and that's why I don't recommend it being used as a core material at all. The composite failed nearly more than 80% of the samples failed after 385,000 cycles, and the amalgam survived with a percentage of 70%, which is really good, after 1 million cycles. So this shows that your amalgam core is much better than the composite core, much better than the glass ionomer core. In essence, that goes back to the nature of the material. It has nothing to do with whether it's amalgam or composite or how it's placed. Metals are simply better at handling fatigue when compared to composites. So you would expect the same behavior of a casted post and core. And that's why I believe that the ultimate posterior post and core system is the parapost system. We're not advertising right now, but when there's a good material, we have to say it. This is a copy of a fiber post, okay? But instead of placing a composite core around it, I can simply place an amalgam core around it. And it's going to handle moisture much better. So in cases where I don't have moisture control or I can't place a well-sealing rubber dam, I would go for this system. And the anteriors, obviously, I would always go for the fiber post to simplify my prosthetic procedure and do a good job aesthetically. So the reason why I don't like to use the custom-made metal post, or the commonly called the post and core, although this is a post and core as well. Okay, so this is a post and core as well, but we all know that we all call this a post and core. In more accurate naming, it would be called a casted metallic post and core. First, you will have to remove all of the undercuts so that your pattern is going to have a clear path of insertion, so that you would be able to place and remove your pattern. And that's not good, right? The tooth is already destroyed. I don't want to destroy it even more. And with a casted post and core, you have to do that. You will end up with a thick cement interface because your lab is going to place a very, very, very thick spacer in order to allow for a passive inserting of the post as well. I've noticed that the lab almost never reaches the end of the canal. They always stay short of the end of the canal. And ironically, the bond strength between the cast metal core and the metal of the PFM, so this part and the metal, if you are placing a porcelain fused to metal, is almost always higher than the bond strength of the cast metal core and the dentine. So this part bonded with the PFM is stronger than this part bonded to the dentine. I'm sure most of you have seen it, even the students in your clinics at university. You find that you have a post and core which is failed and you have the crown cemented with it. What does this mean? This means that the post and core is bonded better to the metal of the PFM and not well bonded to the dentine. Again, we go to case selection. So you look at a tooth like this one, okay? And I wouldn't advise you to do anything about it. You would just go ahead and extract it. What about this one? Should I place a fiber post or should I place a casted post? You shouldn't place anything in this tooth. So here I have 1, 2, 3, and thick walls. I just need a core because the goal of placing a post is to retain the core in its place. The goal of placing a post is to retain the core. It's not to strengthen the tooth. Actually, the post weakens the tooth. So if we don't need a post, we never put a post. Not to mention, in the case of a need of a retreatment, your post is going to stand as an obstacle and it's not going to allow you to perform a retreatment easily or happily. So in this case, no post. But if I had to do a certain selection, I would say go for the metal posts when you need a less technique sensitive procedure. So again, if you cannot isolate properly or if you cannot perform a watertight seal around a tooth, just go ahead for the casted post and core. And when you're performing a technique sensitive procedure, you can isolate the tooth, central incisor, lateral incisor, no problem whatsoever. Go for the fiber reinforced composite post and correct naming and core. Okay, fiber reinforced composite post and core. This is the middle of my presentation. I'm going to continue now, but if you have any questions, I would be happy to listen to them regarding the first part and answer them. Do you have any ready questions? Ala, any questions or do I continue? Ala, I hope I'm still live and I wasn't talking for the past hour or half an hour alone.
دكتور أنا بعت لحضرتك الأسئلة على الشاشة.
شو؟ Okay, I can see the questions now. If we use an amalgam core, should we use with it an opaque material before delivering the crown, especially zirconia and ceramic? Yes, obviously you have to place a layered crown. So you would need an opaque core and then layering on top of that. Despite the fact that I don't like that, I mostly like to do monolithic crowns. Nancy. Okay, so I'm going to continue. So the second part of this presentation. This is a nice book. I advise everyone to read it. I almost always include it in every lecture. Okay, this is an advertisement, paid advertisement. Okay, 12 rules for life. Very controversial book, but I advise you to read it. So I have a similar version, but regarding the fiber posts. So I've compiled 12 rules for fiber posts for you. Since I've seen many failures with fiber posts, Norman tells us 50% failure. In my case, I don't think it exceeds 1% failure. I've placed more than 100 posts in the past 10 years, much more than 100 posts, and I haven't experienced the failures that Norman was talking about. And I think that's due to a specific reason. So my way of placing a fiber post must be a good way. Because if you get 10 clinicians right now, or if I do a survey right now, and if I ask many of you, how do you place a fiber post? I'm sure I'm going to get a different answer every single time I ask someone. Some people etch the canal, some people don't. Some people place a piece of cotton inside of the post space, some people don't. Some people blast the post, some people don't. Some people put silane on the fiber post, and some people don't. So there are a lot of variables when you are placing fiber posts, and in my opinion, placing a fiber post is more technique sensitive when you compare it to even an implant. I think it's more difficult if you want to place it correctly. Placing a fiber post is much more complicated than placing an implant. So these are the rules. I will go one by one. Okay, on these rules. So we have many types of posts. Dr. Rayyan saying Nayar core. I would have to say also that a part of this presentation is inspired by Dr. Rayyan. Okay, so when Dr. Rayyan was in Beirut, he told me one day that there's this machine that you have to get. It's the sandblasting machine. Okay, the Abrasion machine, and I told him, okay, I will go buy it because I trust him. So I went and I bought this machine, and when I used it, I realized that I can never go one day in my clinic without it. Not an advertisement, okay? I don't sell those, but I advise all of you to get an air abrasion unit. It will come in a few slides. So the fiber posts come in variety of shapes and forms, and silanized and not silanized. So I think the variability of fiber posts plays a role also in the big or large failure rates that are reported in the literature. So each one of those should be cemented in a specific way. You should follow the manufacturer's instructions, right? So the first rule, in my opinion, that's how I do the fiber post. I isolate. Okay, so I see many people who place a fiber post without a rubber dam. I see many students and even many clinicians who place a rubber dam to do a class 1 filling. But when it comes to the fiber post, they don't place a rubber dam. I don't know the reason till now. Some people place a rubber dam to do a class 1 cavity preparation and filling. And when it comes to the fiber post, which is most critical in bonding, they don't place a rubber dam. So my first rule is no rubber dam, no fiber post. And if you tell me that the tooth is badly destructed and I am not able to place a rubber dam because I don't have enough tooth structure, I'm going to tell you that if you don't have enough tooth structure, you should not be placing a post in the first place. So the first rule is isolate, no rubber dam, no fiber post. The second thing that that's really important about the rubber dam when we are building up teeth is that the rubber dam most of the times allow us to avoid placing a matrix. So I can build up these margins, okay, without placing a matrix freehand when I isolate it with a rubber dam, because the matrix seriously complicates your life while you are trying to perform a build-up. You get, at many instances, excess in many areas. You are unable to place wedges all over the place. And also, the matrix is going to inhibit the penetration of light by your light cure. Okay? The light cure is going to have to stay at the position of the matrix instead of you being able to cure, maybe in this case labially and maybe labiodistally and then maybe labiomesially. You have full control over your light cure, but if you place a matrix, you can only cure occlusally, which is a big problem. So another advantage of isolating is that you have the freedom while doing the build-up. Number two, your post should not wiggle. Okay, so after you place your post, you have to make sure that it does not wiggle and it does not move left and right. So sizing in this case is extremely important. It should not be loose inside of your canal. Use the smallest post that fits. Okay, so whenever I want to place a fiber post, I don't go and start thinking, okay, I want to, this is a central incisor, I am going to place a blue post. Or this is a lower 6, so I'm going to place an orange post. That doesn't happen. Whenever I have a post space prepared by the endodontist, or even if I prepare the post space myself, I put the smallest post that can fit. Many people like to put a big post because they want to resist fracture. But yet again, I've showed you the literature, I've showed you the failures. Most of the cases, they don't fail by post-fracture. Most of the cases, they fail by post-dislodgement, so loss of retention. The fiber post is really strong. Guys, I advise you all to go ahead to your clinic right now and to sacrifice one post, okay? Sacrifice one post and try to break it with your hands, okay? Do it. It's okay. It's not that expensive. Slightly expensive, but break it anyway because it's a nice experience. And you can seriously find out for yourself how strong the fiber post is. So this blue post, for example, you will never be able to break it by yourself, okay? Yellow small posts, 1.2 millimeters, 1.4. If you are strong, if you are a muscly guy, maybe you can break it. But these things never break. So just use the smallest possible. No need to go inside with the drills and just widen your post space. That's not necessary at all. Use the smallest post that fits. Another thing that I've noticed is that whenever I use the manufacturer drill, maybe that's just my personal experience, but if you share the same experience, then you know that you're not alone. I get a loose post. So the manufacturer drill creates a very tight space, which is exactly the size of the post. So when you place the post, it never reaches the end. So what you do is that you go in and then give it some brushes again, trying to make it fit. So these few brushes, which you have just done, cause the post to wiggle in the canal. So what I do is that I go for the piezo, usually size 2, size 3, and then I use the smallest post that fits in that post space tightly. Never ever. Some people say a piezo 2, okay, but some people say piezo 2, but I say piezo 3, but never 4, never 5. These things are huge and they will cause disasters in your post space. Most of the times, if the tooth fractures, if you get a tooth fracture after placing a post, it was your post space. It's not the post and core, it's not the forces of the patient. You simply prepared the tooth a lot. Preparing the post space with me when I'm working in the clinic never takes more than 10 seconds. I simply go with piezo 1, piezo 2, and I put the post and take an x-ray to confirm that it's reaching the end. If it's reaching the end, then that's good. If it's not reaching the end, I do some more drilling and then I place it. I never spend more than 15 seconds preparing the post space. Neither do I use a piezo size 3 or size 4. And by the way, most of these manufacturer drills are just huge, okay? So be careful of preparing or over-preparing your post space. Piezo is not like gates, okay? So, and the nice thing that I can look at the chat here, I can answer some questions. So, Tiba, piezo is not like gates. The piezo is a reamer, so it have cutting ends. The gates Glidden is safe-ended in the end, and it's like a small little burr. Okay, so there's a difference. Piezo are reamers. Thank you, Dr. Hala, and we will always be your students. You are missed, really, in Beirut. So, never place your post in the mesial of the lowers and in the buccal of your uppers. And that goes back to your root anatomy. So if you look at your lower molars, this is the distal root, this is the mesial root, and you can notice the curvature always in your mesial roots. The distal roots are more straight. That's why we go ahead and place our posts in the distal of the lower molars and in the palatals of the upper molars. Again, look at the palatal of the upper molar and look at the buccal of the also upper molar. Curvature, very similar to the curvature present in the mesial of the lower molars. So to avoid perforations, to avoid catastrophic problems, you should not place your post in these areas, okay? Number 7, limit your post length to 7 millimeters, okay? So if you are measuring from the orifice towards the end of the post, just stop at 7 millimeters no matter what kind of tooth, what kind of fiber post system you are using. Just never go beyond 7. Okay, we are not talking about the clinical crown or the occlusal surface of the clinical crown. I'm talking about the distance from your orifice towards the end of the post space, because the size of your crown or clinical crown could differ, right? But if you want a nice way to measure from a stable landmark, the orifice to the end, never more than 7 millimeters. Because beyond 7 millimeters, you start to experience crazy things happening in the roots, sudden curvature or a sudden narrowing, and you wouldn't want to drill more into that area. So more than 7 millimeters, there's no need to drill. Also, within the scope of the post length, always try to follow a 1-to-1 ratio with your clinical crown. So I've had this patient come with this crown in his hand. It failed. And first, I didn't see the post because it was so small. But then when I took this big picture, I can see that you have a post and core system inside, but the post is nearly half the clinical crown. Okay. And this is an upper molar, and obviously another mistake is placing your post in both canals, palatal and buccal. You only need one. Again, the goal of placing the post is just to retain the core. It's not going to add strength. And have a look at how big this preparation of the post space is. This is a big preparation of a post space. This means that the root in this area is very narrow. So in this specific case, if we're talking about 0.5 ratio between the post and the clinical crown, then this means that the forces of mastication on that tooth transmitted to the post space are going to be automatically multiplied by 2. So a 1-to-1 ratio means the same amount of forces are going to be transferred to your post, from the crown to the post. The forces will be automatically multiplied by 2 if you do not follow the 1-to-1 ratio, or if you follow a 0.5 ratio. So half post, 2 crown, or half post, 1 crown, the forces are going to be exaggerated, so more chance for post dislodgement. Most important thing in the fiber post, in my opinion, is the adhesive procedure. And I showed you in the beginning so many different types of posts, some silanized, some not silanized, some new, some old. By the way, in your clinic, some of you might have the post, for example, which is 1 year old, or maybe it was with the manufacturer or at your dealer, for example, for 2-3 years, and then he sold it, and it's then 1 year inside of your closet in the clinic. Remember that the fiber post is a composite, and composites are eventually containing lots of plastics inside, and plastics get old. Okay, they age. So have a look at the difference in texture between the fiber post in the area here before the tweezer and after the tweezer. So before the tweezer, it's not sandblasted. After the tweezer, okay, it's sandblasted. So have a look how fresh this material is and how old this material is. Do you think if I bonded and the fiber post is just like that, I would get good results? I would get good bonding? What if I place silane, as most manufacturers recommend? Place silane on your fiber post. Do you think it's going to matter with old composites such as this one? So you have to freshen up the surface, and I freshen up the surface by sandblasting or by air abrasion. So air abrasion is the process of blasting that surface with high pressurized powder. It's alumina powder, so aluminum oxide, very similar to the ones that the lab technicians use to sandblast their zirconia or to sandblast their porcelain fused to metal, but with smaller size. Okay, so to blast the PFM or the metal of the PFM, lab technicians use big particles, maybe 100 microns or more. In our case, for intraoral use or even to blast the fiber post, we don't need more than 25 microns to 50 microns of alumina. Phosphoric acid is not a cleaner, okay? I include this slide every single time also I do a lecture, even if it's a different topic, but there's always a place for it. So I know many people who use phosphoric acid to clean the cavity or to clean the post or to clean a crown after try-in. And phosphoric acid, guys, is not a cleaner. If you open the pamphlet of any phosphoric acid etching gel and you read, you will see that they tell you to clean the surface to be etched using a non-fluoridated oil-free prophylactis paste. So they are telling you before placing your phosphoric acid to clean the surface. They're asking you to clean the surface. So if phosphoric acid is a cleaner, why am I asked to place a cleaner or to clean it beforehand? Simply because the phosphoric acid does not clean. Phosphoric acid selectively demineralizes the tooth. Okay? It selectively demineralizes the tooth, whether it's enamel or whether it's dentin. But if you have debris on the tooth, the phosphoric acid is not going to remove them. If you have plaque leftovers, the phosphoric acid is not going to simply make them disappear. If you have minerals, yes, the phosphoric acid will make them disappear. So for the fiber post, I'm not going to place phosphoric acid because simply it's not going to be doing anything. Okay? I have to mechanically etch the tooth. And by the way, the sandblasting machine is also called a micro etcher. Okay? They call it a micro etcher because it micromechanically etches the tooth and it creates areas for mechanical retention. So this is another example of a fiber post that I sandblasted, and you can see here in this area, this is blasted, okay? And this is not blasted, and this is blasted. So this is blasted, and this is not blasted. And you can see the difference in texture. Crazy difference in texture. Now, after I blast it, I'm going to place my silane, the silane coupling agent. Okay? As you all know, if you want to bond old composite to new composite, in our case, the old composite is the fiber post because it's pre-polymerized, and the new composite is the what? It's the resin cement. So in this case, silane is my best surface treatment after blasting. Again, here's another example of the same post before blasting and after blasting. Does any of you have some white plastics in his clinic? I'm sure many of you have some devices with white plastic. The white plastic with time, it ages. And as you can see, it becomes yellow like this fiber post here. So you simply hold your blasting machine or the air abrasion unit you have and you blast it. It only takes 10 seconds and you have fresh composite ready for bonding. I hope you can see the difference, and the quality of the broadcast can show you the difference in the upper post when compared to the lower post. On my screen, it's very clear. I also use it intraorally. So whenever I want to clean a pulp chamber, okay, I simply blast it. So that's the result before blasting. And then after blasting, have a look at the difference. That's really amazing. Also, after blasting, you can notice that I can start to see things I didn't see before. You can see a crack in this area, okay? Before blasting, because of the presence of debris, it was not apparent. I couldn't see it, okay? Have a look at this crack in this area and how it was not visible because of the presence of the debris. Have a look at this tooth again. Debris, remnants of gataperca everywhere, and then I blast it and have a look. Beautiful, smooth, micro-etched surface that's ready for bonding. If I have a failed veneer, for example, and I want to re-cement it, I would just scratch the tooth to mark the remnants of the resin cement. And after I've scratched them, they are visible as black markings on the tooth. You can see in this area, we have remnants of resin cement here and here. If you are going to use the burr to try to remove them, then the next time you are going to cement your veneer, the cement thickness is going to be really big. And this is going to negatively affect your bond strength. You're going to get weak bonding because of the thick cement interface. So I go ahead and simply blast it. Have a look. It's like magic. Okay? Just erases everything without removing much of your tooth structure. That's why I recommend that this machine to be present in every single dental clinic. Okay? I don't understand up to this moment today in 2022 why not many clinicians use it. It's very rare, although it's extremely beneficial. So after you blast, now the etching part is slightly controversial. So when I etch, I like to etch everything, okay? But some people don't feel confident placing an etching gel inside of the post space because they might be scared that they wouldn't be able to get it out. Similar to the adhesive. Some people would be scared that maybe they would have pooling of the adhesive on the inside and they wouldn't be able to get it out. In my opinion, if you are working with good magnification, you have no problem. You can see everything. So go ahead and etch inside and bond inside. If you are not working with magnification, then my opinion is to avoid doing anything inside of the canal and simply just use a self-adhesive resin cement. So in this case, I keep on placing the paper points first, second, and this is the third. I place it and it comes out dry. So when the paper point comes out dry, then I know my post space is all ready for my adhesive procedure. Now we come to the cementation part. So number 10, okay, you have to take care of your product interactions. Eugenol-based sealers should never be used if you are going to go ahead and do adhesive dentistry later. So I know that most of you use the zinc oxide eugenol sealer for endo, but if you use that and then you use a resin cement sealer later on, you have a big chance of causing an inhibition of the polymerization of your resin cement. So the resin cement might not polymerize properly, and that's basically disastrous in a post and core system. So to avoid that, you have to avoid the zinc oxide eugenol based sealers when you plan to use the post and core later on. Another thing that you have to avoid using, and I know that not many people know that, but if you go ahead and look it up in the literature, you will find so much evidence. You will find so much evidence for this. It's heavily supported by the literature. So most of our adhesives currently are single bottled adhesives, okay? So we are talking about either a 5th generation adhesive where you have the primer and the adhesive together, or you have a 7th generation adhesive all in one system, so no need for etching, okay? Acidic monomers together with a primer and adhesive all in one bottle. What they've come to conclude after so many studies and so much testing, even in vitro testing in the lab, is that when you use these kinds of adhesives, the single bottle adhesives, many people think that it's the universal adhesive only, but that's not true. It's not only universal adhesives. It's single bottle LC light cure adhesives. They don't bond properly to dual cure cements, which we use with fiber posts. Okay, we never cement a fiber post with glass ionomer cement. We always cement it with a dual cure resin cement. It's always dual cure because the light cannot penetrate into the end of the post space, and for this reason, it should be dual cure. But turns out that these dual cure cements, they don't bond properly to the single bottle adhesives. And that's why I was saying that if you are not sure, okay, of your bonding procedure, just go ahead and use a self-adhesive resin cement alone without anything. That would be much better than using a single bottle adhesive and later on coupling it with a dual cure adhesive. So never use the single bottles, okay? So to be on the safe side, you avoid all single bottle light cure adhesives when using the dual cure resin cements, okay? You can check out these references and you can even find more of that on Google Scholar and PubMed. Tens and tens of studies on this topic. So extremely common adhesive, okay? Again, we're not advertising for anything. These are all good adhesives on the market. We all use them. all of them don't work well when you are trying to utilize a dual cure resin cement. You have to couple it with a chemical curing agent. Okay, all single bottle light cure adhesives need to be avoided when you are trying to be utilizing a dual cure resin cement. So we know that some companies release a self cure activator, so you can simply use their adhesive and add few drops of the self cure activator, and you're safe. You can use it with a dual cure resin cement. Always remember, dual cure resin cement, the adhesive should be dual cure, should not be single bottle light cure. Or you go ahead and use a chemically cured adhesive. This one was by Dentsply. This is by Tokuyama. Okay, they have this two-part system adhesive. You mix them up and you place them inside of your post space. Let it dry and it's done. No need even for curing. This one is compatible with the dual cure adhesive. So you apply your silane coupling agent on the post after the sandblasting. Could be a one-part system silane and could be a two-part system silane, no problem. Both will work well. And most importantly, if you are going to bond inside of the canal, and I bond inside of the canal, if you are going to bond inside of the canal, then you have to cure inside of the canal. Okay? I have these small curing tips. I advise every single person to get them, because they allow you to get extremely close to where you want to cure. Huge advantage. If I wanted to place a big curing tip, I would have to stay away from the tooth. So this is a huge advantage. Look, guys, I can insert my curing tip inside of the tooth and reach areas not possible with the traditional curing tip. If I had a traditional curing tip, I would have to stay here up. And that's a problem, because these are around 4 millimeters, and 4 millimeters away would nearly cause me to lose half of the strength or the irradiance of my curing unit. And that's extremely problematic, okay? Because the light is not going to reach the end. Again, showing you why, if you're not sure of your adhesive procedure, don't bond inside of the canal. Simply rely on your dual cure self-adhesive resin cement. Avoid all of that. Don't complicate the procedure. If you're sure of it, if you're sure of your curing unit, that it has good irradiance, then go ahead and place your adhesive inside of the canal. If you're not, don't do anything and rely on the power of your self-adhesive resin cement. Here's another advantage of my small curing tip. Look, it allows me to get inside of my matrix into a class 2 cavity so that I could properly cure my bonding on the marginal areas. And as you all know, that's where the failure always happens in the case of class 2 fillings. We always see the failure and the recurrent caries in the marginal areas. One reason is because the bonding agent is not cured well, or the composite is not cured well in that area. Because if you are curing here, again, you've lost around 5 to 6 millimeters in depth, and that's going to decrease the power or the irradiance of your curing unit. Not enough light is going to reach that area. The traditional curing tip is 10 millimeters, and this small curing tip is 4 millimeters. By the way, it could work on any curing light, the fiber optic tip. You can buy it separately. You don't have to buy a whole curing device, but you have to make sure that its base is the same diameter as your curing unit, okay? So usually these come with two measurements. So they come, for example, 10 millimeters here, and then, for example, 16 millimeters in the base. So if you want to buy it, just take it with you to your dental supplier and select the correct one for your curing unit. And you can simply switch between those. One time put the small curing tip when you need it, and another time use the bigger tip when you need it. Now, this is extremely important. Okay, guys, this is extremely important, and why I want you to know to really concentrate now, because I know that many of you are going to give the curing unit to their dental assistant and allow her or him to do the curing for you, right? Many people do that, and that's completely wrong and bad. Because have a look, if I'm curing my post, okay, I'm curing my post, this is good. Okay, again, let's repeat. This is good. Okay, now have a look. I just twist the curing unit slightly to the outside. Okay, slightly I twist it palatally, and then I lose most of the irradiance which was being absorbed by this trans-illuminating fiber post. Okay, so angulation of your curing unit is extremely important. Again, this is good. Okay, this is good. And now with a slight tilting towards the palatal side, despite that the axis looks right, but the tilt angle is not correct, and the fiber post is not absorbing the irradiance of the curing tip. So again, it's extremely important to see that your post is glowing after curing. Okay, your post is glowing after curing. It needs to really absorb so that most of that light is going to reach the end of your fiber post. That is extremely important. So another thing that's extremely important is to cut the post to the correct length before you actually place the post inside of the post space. Okay, it's extremely important to cut the post before you actually place it and cement it, rather than to place a long post and then cut it. Why? So the first reason is that you don't want to cause vibrations while the cement is not fully cured yet. We never know if the cement is cured or not cured within the first 3 to 4 minutes. This is a dual cure cement. So we want to avoid vibrations as much as possible. The second thing is what I was saying right now. It's this trans-illuminating potential of your fiber post. Have a look. The irradiance and the power of your light is extremely strong here, but as you go in depth towards the end of the post space, it's getting weaker and weaker. So let's say you wanted to place a post which is this long. All of this is wasted light. Okay? All of this is wasted light. So if you cut it here before you cement, place your cement and then place it and get your light cure and start curing here, then you have gained the advantage of irradiating all of your post here within these 4 or 5 or 6 millimeters, which will give you initial bond strength which is acceptable. Okay, eventually we'll have to prep. I will have to go around with my burr and prep the tooth. So you will end up with vibrating the tooth inevitably. That's going to happen. For this reason, you want good initial bonding and good initial bond strength between the resin cement and the post, and the resin cement and the post space, so the dentine as well. That's the last one. Obviously, you should never inject your cement with these large tips. Okay? These incorporate big bubbles, and even these small ones, have a look. There's a big chance you incorporate bubbles. So you have to place cement inside of the post space and also on your post. Okay? And then after you place the post inside, you start to pump up and down. 1, 2, or 3 times, pump up and down to remove any of the air bubbles inside, and then you place it and cure without touching the post at all. It's very important and critical that within the first few seconds while you are curing and while this cement is solidifying, You want to avoid touching the post by accident. Again, another reason why you should not give your curing unit to the assistant and let her cure. Because if she cures, she's going to rest that curing tip on the fiber post. And if the cement is gradually solidifying within the first few seconds of curing, and the post moves, you are going to lose most of your bond strength. Most of your bond strength is going to be lost if that happens. So you have to be very careful. So never this big curing tip. And if you are using a resin cement, and I've had personal bad experience with the lentulo spiral, just try to avoid this one. Just get the small curing, the small injection tips, and you will be good. The lentulo spiral could cause heat generation inside of the cement, and it would cause premature setting of your cement. Your cement could turn into a crumbly type of solid, and it could block your space. So imagine injecting a cement inside of the post space, then placing the post, and then suddenly it does not want to get inside. I think you would get a mini heart attack if that happens. Small heart attack. For this reason, just avoid anything that could generate heat inside of the post space. Just get the small tip, inject your resin cement in a stress-free environment. That's another reason why I say place a rubber dam, because you want this whole procedure to be stress-free. With the build-up, if it's an anterior tooth, I never ever use an enamel shade, because we've done that before, and it really complicates the process of aesthetically covering that tooth up. Okay, just use an opaque shade to build up your tooth. Okay, really important, opaque shade, because later when you want to place your crown, the enamel shade, which is this one, or this tube in this case, okay, is going to be translucent. It's going to show through. The tooth is gonna look gray, and this is a central incisor, for example. Imagine trying to do a central incisor, which is very difficult, and add to that difficulty an underlying gray core that you need to cover up. Okay, so make things easy for yourself. Just put an opaque material, opaque composite on the facial surface. Doesn't have to be everywhere. If it's just on the facial surface, that's enough. An opaque dentine, for example, A3 or A2 composite, that would be really good. And finally, you are going to go ahead and prep your crown. Another video of why it's extremely important to properly angulate your curing tip. Have a look. This is not good. This is good. Okay. This is not good. This is good. Not good. Good. Just a simple twist within your light cure can make a big difference. So I always say that you have to actively cure. You have to actively cure. Curing is a skill, very similar to placing a composite, very similar to putting an implant. To know how to properly hold your curing unit, that's a skill, and you need to concentrate while curing, and again, to actively cure and not passively cure. It's not enough to just hold your curing unit. You have to actively place it in a position that would make the whole tooth irradiate. Those were my 12 rules for placing the fiber post. In the end, you can prepare your questions if you have any, and I might answer now any of the questions which I see in the chat. But in the end, I want to tell you that it's true that in the literature, the failure rate of the fiber post is extremely high. But I can tell you from personal experience, if the fiber post is placed well, I don't think that you will experience failures. On the contrary, I think, and I always believe that whenever you can place a direct filling, or whenever you can do a direct procedure, do it. It's much better than going for an indirect procedure. And we have lots of evidence on that in the literature. Always, when direct is possible, go for direct, if you can follow the correct protocol. Yes, we said that the post and core is less technique sensitive. And it's similar to amalgam, right? It's similar to amalgam filling. Amalgam fillings could be placed, okay, no isolation, blood inside of the cavity, fluids coming inside, and the patient is okay. Okay, why? Because the amalgam as a procedure is not technique sensitive. Try to do that with the composite restoration and start to count your failed restorations with time. Okay, so composites and adhesive dentistry is always technique sensitive. If you want to go ahead and use a fiber post, you will need to perform that procedure with proper care and meticulously. And again, if you can go for direct, just go for direct, and that's it. I'm going to try to read the questions. Okay, what about the alveolar crest? Here, I was talking about the length of the post and that it should be maximum 7 millimeters from the orifice. So whenever you go with 7 millimeters maximum from the orifice, you almost always cover half of your alveolar crest. Okay, so half of the bone length. Most of the times when it's 7 millimeters, you just cover that automatically, so it's not a problem. Exactly. Same. Alumina or aluminum oxide is the same material used for sandblasting the tooth structure. Same material, but for the teeth, we use smaller particle size, usually 25 microns. For metals, it's bigger size, 100 microns and more. For ceramics, it's usually 50 microns. You can get the 25 or 50 microns at your clinic. It's just one barrel, and it would last you for a lifetime. Mona, do we need to etch after sandblasting, or that depends on aluminum particle size we used? Okay, so if you are talking about sandblasting the fiber post, you don't need to do anything. After you blast the fiber post, you just place silane, and that's it. Now it's super ready for bonding. Very highly reactive surface after sandblasting is satisfied with the presence of the silane, which will then bond to your resin cement. So that's more than enough. If you're talking about if we need to etch the tooth, I talked about that. You are free to do that. If you want to use for example, 4th generation adhesive, you have to etch the tooth, obviously. You can use a self-etching adhesive. You can use a self-etching resin cement and avoid bonding inside of the canal if you are not confident of the materials that are present with you. Thank you guys for the people saying it was interesting. Thank you. Okay, so here's another question. Do we need to sandblast the tooth or the fiber post? And do we need etching after sandblasting? Again, so you can sandblast both. I sandblast both. Okay. But regarding the fiber post, you don't need to etch it. Again, etching gel, okay? Etching gel is a selective demineralizing agent. The fiber post is a composite. So the phosphoric acid is not going to do anything, okay? Exactly. Ahmed Abiad, specifically the hydrofluoric acid as it acts on the porcelain, specifically feldspathic, 37% phosphoric acid doesn't alter the ceramic surface morphology. That's true. But sometimes we can use the phosphoric acid on Emax after placing the hydrofluoric acid in order to get rid of the layer of salts which is present. Okay, so after placing HF on the lithium disilicate, you either have to place it in an ultrasonic bath to get rid of the layer of salts that form on that surface, or you have to place the phosphoric acid because it could also get rid of that layer of salts to improve the bonding. Is it a must to use the small mixing tip, or may I introduce the cement by the post to the canal? I would very much prefer to use the small mixing tip. I would very much prefer that because you have air inside of that post space. So you have to inject something inside of that post space to let the air get out. And even when you inject, you will have some air left inside. That's why I told you, you place cement on the post and then you pump it up and down to get rid of the air. So you have to inject the resin cement inside. If I'm using a self-adhesive cement, I only need to sandblast the post and silane the post and etch and bond the tooth. If you are using a self-adhesive cement, actually you don't need to etch and bond the tooth. Again, if you are confident of your bonding procedure, and if you are using a chemically cured bonding agent like the one I showed you in the presentation, then yes. If not, the self-adhesive resin cement on its own is better. What are the alternatives for zinc oxide sealers other than bioceramic sealers? You have resin sealers, okay, resin-based sealers. Now, if you used the zinc oxide eugenol, okay, let's say you used it, or your endodontist used it, or if you don't know what your endodontist actually used, okay, what should you do? Well, you have to take good care while preparing the post space. You have to brush the walls and try to freshen up that surface as much as possible to be able to get rid of the layer, of the superficial layer of eugenol which is present. Okay, you have to try as much as possible to remove that layer. If endodontic retreatment was needed, is post removal possible considering its high bonding strength? We don't really think about that. So when you have reached a point where you are placing a post, I personally believe that this is probably the last treatment you will perform to that specific tooth, okay, before an extraction. In my opinion, after placing a post, it's not worth, if you get an infection, for example, it's not worth getting that patient through 1, 2, 3, 4, 5, 6 sessions of free treatment, trying to remove the post, trying to clean up the tooth, and trying to get rid of that infection for a procedure with such low prognosis. I believe that the post is the last line of treatment before an implant. So when I place a post, then I know that I'm not going to do anything after it. Okay, that's my personal philosophy. Now, if some people want to remove the post and try more with that tooth, it's up to them. This is an individual preference. But when I had placed the post, I know that this is the end. Okay, the tooth is badly destructed. I'm trying to save it for one last time. If we have an infection again, I think that the patient is going to be better off with an implant than removing a crown, removing core, trying to remove the post. Sometimes the removal of the post is so difficult that you end up with a perforation or with another complication, especially if you're not working with magnification or if you don't have a microscope, okay? If you don't have a microscope, to be honest, removing a post is basically worthless, okay? It's a worthless try. I don't advise, okay? You're most likely going to end up with a perforation. Okay, so please repeat the last point about light curing angle. So I was just saying that your light cure should be angled in a way that the post is irradiated well. Okay, I can repeat that part again. If you are curing the core, have a look. This is good. This is bad. Okay, and it's just a small tilt that could change the whole irradiance, because again, the highest irradiance that you get is from the middle of your curing tip. The edges give you low irradiance. So if you want the highest power, you have to align the middle of the curing tip so that the whole core is going to irradiate. Okay, you want it to blow up with light. That's extremely important. Okay, any other questions, guys? Any questions? Ala, should I go? Thank you, guys. I'm really happy. I'm really happy you enjoyed it. Thank you. Ala, do I go? Thank you so much, guys. These are my contacts. If you have any questions or if you need anything from me, I'm always ready. You can contact me always. Ala, do I go?
اوكي يا دكتور لو حضرتك خلصت تمام.
Okay. Okay. Thank you, guys. Thank you.